Hi, I'm Mike Contos for Cardiosource. Today I will be speaking with Dr. James DeLamos, who's participated in a number of interesting studies measuring troponin in asymptomatic patients. He's currently professor of medicine at the University of Texas Southwestern Medical School. Our topic of discussion for today is the implications of troponin in asymptomatic patients with structural heart disease. James, just a few years ago, we thought that troponin elevations were present only in patients who had acute myocardial damage. However, a number of studies you participated in, as well as others, have demonstrated that when using the newer, more sensitive assays, troponin is detectable in a variety of patient populations who are actually asymptomatic at the time of sampling. What are some of the conditions that are more commonly associated with detectable troponin in these asymptomatic patients?
Mike, I think you're absolutely right. With these increasingly sensitive assays, it's become apparent that it's common to measure troponin levels in individuals that have no symptoms at all. Back when we were using standard assays, when we looked in the general population, it was fewer than 1% typically that would have a measurable level. But now that we're using highly sensitive assays, the vast majority of individuals with chronic cardiovascular diseases actually have measurable levels. For example, there have been studies in individuals with chronic coronary disease, with normal LV function, and with chronic stable heart failure. And in both of those studies, close to 100% of individuals had detectable levels with the highly sensitive troponin T assay. In the general population, the proportion of individuals with detectable levels is a bit lower. In younger populations, like our Dallas Heart study, it's about 25%. But when you get to an older population, middle age or greater than 65, it's about 2/3. The kinds of things that drive whether an individual has detectable levels are whether or not they have known cardiovascular disease, and importantly, whether they have markers of subclinical disease. And what we see most strongly are measures of structural heart disease, LV hypertrophy, defined by wall thickness, chamber dilation, LV systolic dysfunction, even if it's asymptomatic. Renal disease is a really powerful determinant of levels. What's equally interesting are what doesn't determine the levels. It turns out that atherosclerosis measurements don't really influence variation in troponin among asymptomatic individuals. Males have about threefold higher levels than women and much more likely to be detectable for reasons that we haven't figured out yet. And African Americans more likely to have detectable levels than whites and other ethnic groups, almost certainly because they have more hypertension and hypertrophy on whole.
In many of these studies, when we're measuring these levels, they seem to have important prognostic value for identifying those patients who are later going to go on and have heart failure or ultimately die. This is really in contrast to what we see in the ACS population, as they are much less predictive of patients who are going to have acute MI. Why would this be?
Well, I think you're absolutely right. The associations that we see with heart failure and cardiovascular death in asymptomatic individuals, whether you're talking about the groups that have known cardiovascular disease or even the people that are perfectly healthy, are really robust. And they predict death and heart failure, but interestingly, the associations with MI are much less robust. And I think that the reason for that goes back to the findings that we have when we look at the detailed phenotypes. When we think about what associates with troponin in the population, it's muscle processes, hypertrophy, LV dilation, LV systolic dysfunction, but not atherosclerosis. So in asymptomatic individuals, whether it's those with chronic coronary disease, those with chronic heart failure, this is a muscle test, troponin. It's reflecting changes in the cardiomyocyte milieu. What it isn't is an atherosclerosis test, and that's in distinction to what we see in the acute coronary syndrome arena.
As with any new test, we often have a lot of other information, both clinical and other biomarkers that we've measured. How does troponin, when measured in these patient populations, compare when we have BNP or C-reactive protein information?
Mike, it compares quite favorably, and I agree with you that before we even think about adding a new test into our clinical tool set, we've got to demonstrate convincingly that it adds additional value to the things we're already measuring. You know, we participated in 3 large population studies: the Dallas Heart study, which was younger individuals; ERIC, which was middle-aged individuals without cardiovascular disease; and then an older population, the cardiovascular health study. In each of these studies, troponin added clear value both to CRP and end-terminal proBNP, improving measures of the area under their RC curve, reclassification measures and such. Interestingly, it outperformed CRP in all of the studies, including when we looked at a coronary disease endpoint. We've already talked about the fact that troponin is really a heart failure marker, not a coronary marker, but it seemed to outperform CRP even for coronary disease. So in our opinion, it looks to be a much more promising risk prediction marker, for example, than CRP in the population. Now, what needs to happen next, obviously, are the delineation of what we can do to modify that risk.
Yeah, I was wondering that the frequency that we're able to detect these elevations, are we going to reach the point or soon going to reach the point where we can use troponin as a measurement to detect patients who have structural heart disease rather than performing, say, an expensive imaging test like echo?
It's a great question, Mike. I'd say the answer is sort of yes and no. I think that the correlations with structural heart disease and risk are robust and significant. The challenge is that these markers are promiscuous in the sense that they don't reflect one disease process. Troponin tells you that you have subclinical myocardial injury. It doesn't tell you what the etiology of the injury is. And for that reason, I think we're going to need to do additional testing when we define an abnormal troponin or natriuretic peptide value in order to determine what to do differently with the individual. So I think they're going to function, if they make it to the clinic, as gatekeeper tests, where we would perform a muscle screening test, if you will, with the troponin and natriuretic peptide. And if they're abnormal, it's likely to trigger more imaging evaluation to identify the source of cardiac injury.
Most of the studies that have been performed have measured troponin at one time point and then looked long term to see what happens to the patient. Obviously, the next question would be, what if we measured it at multiple time points? Can we look at the effects of intervention on that value, much like we do with statins on cholesterol?
I think that's definitely the next logical step in evolution, because if we can demonstrate that modifying the levels modifies risk, then you have a test that might be used for serial monitoring. We do have data from the cardiovascular health study, which was led by Christy Filippi in Maryland. And in that study, about 2/3 of the 4,500 individuals that were enrolled had a second troponin measurement that was done 2 to 3 years after the first one. Those individuals whose levels increased by 50% or more had a notable increase in the subsequent risk for death and heart failure. On the other hand, people whose levels fell by 50% or more had a notable decrease in risk. This suggests that the risk that we identify with troponin might not be fixed and might be modifiable. The obvious question coming next is, what are the things, either pharmacological or lifestyle, that we can do to modify troponin levels and modify an individual's risk for heart failure? Now, I think it is interesting that troponin has some characteristics that make it attractive for serial monitoring, which contrasts, for example, with BNP and NT-proBNP. The biggest one is that it doesn't change much over time if there's not a clinical change. The within-person variation is quite low, so we can assume that changes in values likely represent a change in the structural phenotype. With natriuretic peptides, the levels bounce around quite a bit, and there's quite a lot of biological variation, so it's sometimes hard to determine whether moderate changes in natriuretic peptides represent clinically meaningful changes.
Well, James, thank you so much for that great discussion on troponin in asymptomatic patients. For more information, please visit our website at the biomarker community at cardiosource.org. Thank you.